So I think we're going to get started. Thank you all for coming. This is a very special medical education grand rounds because I think it highlights for the institution the quality of the medical education research work that's going on at Sinai. And last year, these are our blue ribbon winners. So there were 4 blue ribbon winners. 2 went to the AAMC on behalf of Mount Sinai. And we're going to have presentations from the 2 that went. We're going to only hear from 1 today because a couple of the authors of the first presentation have since graduated and moved on to fellowship. But suffice it to say that 2 of the blue ribbon winners came from the Department of Pediatrics. Very well represented in the House as well, and generally very well represented in medical education research. So our first presentation today is by Dr. Joanne Hojsak, and the title is Development and we're going to switch it. Sorry, Listening to Your Patient, Honing Physical Exam Skills Through Human Patient Simulation. And let me tell you a little bit about Dr. Hojsak. She is a graduate of the Mount Sinai School of Medicine and completed her pediatric residency and chief residency at Mount Sinai. She received her subspecialty training in pediatric critical care at Baylor and eventually returned to Sinai as a pediatric intensivist. She's an associate professor of pediatrics, chief of the Division of Pediatric Critical Care, and director of the Pediatric Pain and Palliative Care team. And Dr. Hojsak became involved in undergraduate medical education as a preceptor for the Art and Science of Medicine Year 1 course in 2003. She has been course director for that course since 2009, and she will speak today about an addition to the ASM1 curriculum that has continued for the last 3 years, and her co-author, Dr. Charlie Murphy, cannot be with us today. So welcome, Joanne.
Thank you, and I really have to give a lot of credit to Charlie for doing all of this too. So I'm kind of channeling his slides here right now, so I'm just really talking for him. We've done this project together for the last 3 years, and it's something that we've continued because of its popularity for all this time now. Hey, okay, so we do human simulation for the purpose of teaching physical exam skills. And so what we thought about a couple of years ago is that the standard way of teaching physical exam skills is tried and true, been done for a long period of time, where you do a demonstration or you teach the different methods, and then the students practice with each other, okay? And then eventually, with time, they practice on patients. All of that is really good, but we found that especially in watching their final assessments, that many of them just went through the motions, so that they would essentially listen to the lungs. Okay, I'm listening to the lungs, and really just kind of go through the whole thing to the point where sometimes I see that the stethoscope is kind of hanging out of the ears, and they're still doing like this for the assessment, you know. And so we were trying to figure out how to make it more real and how to make it more focused for the students. And one of the ways we thought was that if they had to identify problems, so they actually had to localize an abnormality, that perhaps that they would understand what was going on a little bit better and appreciate why we listen in certain areas and why we do what we do. And so we introduced our simulator guy, and he has problems, okay? So he has both pulmonary problems and he has cardiac problems in 2 separate scenarios, so we compartmentalize a little bit in order to introduce it so they understand both the pulmonary exam and the heart exam. I let the students name him, okay, when we start, because we get a full history on him, and he's had many different names over the course of 3 years, often after a classmate that they think resembles, okay? A popular name recently is Carl, okay? I'll leave it at that. All right. So the peer-to-peer exam model still continues, okay? But at the same point, we have introduced this as a little bit of a supplement to the actual exam after they've done the actual learning of how the physical exam is done. Okay. So again, we're answering the questions: why am I auscultating in all these areas? What am I really looking for? And what's the point of all of this? Okay. Again, adults need to know the reason for learning something. They need to they learn the what better if they understand the why behind it. So that's why we do this. Okay. All right. So I'm just going to move right on to the simulators. Okay. So we started this in the year of 2010-2011 academic year, and we have 2 cases: a pulmonary exam and a cardiac. And we have to run the 140 students through these simulator sessions, and we've done them in the middle of their clinical sites where they're actually going out to visit patients. So instead of going out to visit patients on one day, they go here. And so there are 2 instructors, it's both Charlie Murphy and myself, and we'll do 2 different classes on a Wednesday each. Okay, so we'll run about 20 students through the course every Wednesday. Okay. Okay. All right, so we do it as a real case, even though he's a plastic guy. And so we actually let them obtain the chief complaint and the history of present illness from the patient. So in that, we also give them a little extra history-taking skill work as well. And I try and really focus on getting a pertinent HPI for a pulmonary problem and a cardiac problem. So it kind of begins the clinical reasoning process for the first-year medical students as well. I actually supply them with their past medical history and social history and family history because of in the interest of time, because it really is a lot to get into a 90-minute session. And then the students do develop a differential diagnosis from the history, and then we go to the physical exam to try and confirm that. Okay, and so here we go. All right, and so we begin with a pulmonary case, and then we move on to a cardiac case. The other nice thing about these patients is that they don't mind if 5 people examine them at once, whereas real people somehow mind that. All right, so go figure. All right, so they don't mind. So we got the whole case written on the board behind us, and they're in the process of trying to figure out what's wrong. And for the pulmonary case, I really emphasize going to all the different lobes of the lung, inspiration and expiration, looking for inspiratory abnormal sounds and exhalation and expiratory abnormal sounds. Same thing with the cardiac. They're going to the and looking all over for the murmurs and going through the whole process of the cardiac exam. Okay, so the pulmonary case is a 25-year-old male with an acute asthma exacerbation and right middle lobe pneumonia. That's what it comes out to be. So the physical exam findings that are abnormal are diffuse wheezing as well as crackles in the right middle lobe area. And so they again identify the crackles. They have to localize where everything is. And we show them an x-ray at the end of it all too. And we also do a medication intervention, which is a little magical because we actually make them improve quite quickly with that. But we get rid of the wheezing at that point so they can just hear the crackles distinctly. And there's a change of vital signs that go along with this. And there's your right middle lobe pneumonia. And there you go. And so the second case is a 35-year-old male with heart failure secondary to mitral and aortic valve disease from a previous rheumatic heart disease as an adolescent. And so we go through quite a bit of heart failure issues as well as murmur issues. Along with this. And so we teach them, this is probably one of their first introductions to heart murmurs. They don't do heart murmur work in physiology at this time anymore. They just do normal human physiology right now. So we go through all of this with them as well. We also give a dose of furosemide, have the crackles magically disappear a bit so they can hear the murmur. It's a little bit of a time warp, but okay. And there's our big heart to go with it. Okay, and then we looked. Okay, so we had everything else in physical exam components of ASM remained the same throughout the years, including the final assessment or final exam. And the final exam consists of a recorded encounter with a standardized patient where they get a full history from the patient, and then they do a vital signs and cardiac, lung, and abdomen exam. These are assessed through a checkoff list that is done with various faculty, generally not the faculty that have these students on a weekly basis, and so there are people that really don't know the students as well. And the score is done through a checkoff list. The recordings are kept for the students for the next year, and they get to watch themselves in ASM2, which is always painful. All right, and so we looked at, so the assessment remained the same, and so we tried to use that as a tool between the two just to see if there was any appreciative difference in cardiac and pulmonary exam issues. Now, granted, there are other experiences that we can't control for, such as the fact that the students go to different clinical sites and have different exposures with patients. But this was the one thing that was very standard, so we took a look. All right. In addition, we did a post-session anonymous survey with the students to find out how they liked it. Okay, so we broke up a lot of the things that are checked off on the physical exam into different categories, and they're pretty obvious in cardiac, pulmonary, and abdominal. Remember, this is not an abdominal simulator, but we left it in there as far as comparing it almost as an internal control, just to see if there was an appreciable difference in abdomen scores from 1 year pre-simulator and then post-simulator. Well, then, it could be that just that we're doing a better job teaching, okay? But we left it in there as a control to see if there was any appreciable difference. So you can see students do fabulously no matter what you teach them. All right, so that the organ system tested is on the bottom. I have a pointer on this, I think. Yeah, it's on the bottom. And the % correct answers are here. So you see they do well anyway. However, there was because there are so many questions and so many students, there was a significant difference for cardiac and pulmonary exam when you do the math. So that the light gray bar is the previous year of tests, and then the dark gray bar is the year immediately after the simulator. And so there was an improvement in their cardiac scores and their pulmonary scores for both, for the simulator group and not for the other. If you notice, the abdominal group, just by chance maybe, or actually came out dead even. All right, so. Okay, and then when you look at the clinical history or exam skills that the students learned and really the % improved comfort level, the students uniformly felt so much more comfortable in listening to breath sounds, identifying wheezing, crackles, murmurs, and whether murmurs were systolic or diastolic. So they really, it's become a bit of a favorite session for the students. So it's, in conclusion, it can be introduced successfully into a first-year physical examination course, and I think has some benefit as far as clinical reasoning and learning how to take a history, as well as identifying different areas of, that you want to focus your physical exam on with some abnormal sounds. And there you go. Thank you very much. I want to thank Rob Fowler, who did a lot of the statistical analysis, and Rainier, who's always a support. Okay, ta-da.
So our next presenter is Dr. Leora Mogilner, and she's also from the Department of Pediatrics. So Leora is an assistant professor in pediatrics and has been faculty at Mount Sinai since 1996. She is the course director of the Advocacy and Community Block Rotation for Pediatric Residents. She also runs the Reach Out and Read at Mount Sinai, an early childhood literacy program based on pediatric in the outpatient department. She's also medical director for Reach Out and Read of Greater New York. Her areas of interest include early childhood literacy, advocacy, and community pediatric training, and she also enjoys mentoring resident projects. And Leora was one of our presenters at the AAMC from Sinai.
Let's figure this out. Okay. Good afternoon. So I'm going to be talking about a new curriculum that we developed, teaching obesity and advocacy for pediatric residents. So ACGME guidelines mandate that pediatric residents must be provided with structured educational experiences to prepare them for the role of advocate for the health of children within the community. So what exactly does that mean? How do you go about doing this? Well, CPTI, the Community Pediatrics Training Initiative, which is a program within the American Academy of Pediatrics, actually lays out a whole group of educational goals and objectives that residency programs can use in order to meet these objectives. So, for example, I don't have to go through all of them, but pediatric residents need to learn how to give culturally effective care to children and families from all types of cultural backgrounds and diverse communities. They need to develop advocacy skills on a variety of child's health issues and understand the legislative process. They need to be able to provide a medical home for their patients, be competent in the care of children from a variety of special populations, including immigrants, refugees, homeless children living in homeless shelters. They should be able to serve as a consultant or a collaborative partner with a variety of multidisciplinary groups and other community members, be able to interact with educational child healthcare settings to improve the educational and health environment of these settings, also be versed in public health and prevention, and also have skills in inquiry and application to improve child health. So being comfortable doing EBM, doing QI. And there are a number of different models that we can see, or curricular models across the country that different institutions use to teach advocacy and community pediatrics. And my experience was that the models differ depending on the resources available within the institution. So for example, at Stanford, they actually have required block rotations during both first and second year of residency. And they actually do projects as well during each year. And then interested residents can apply for sort of an advanced called the STAT program during their third year, where they have additional time and a mentored project, which is a longitudinal project. University of Rochester, also another leader in the field, they have a 2-week block that all interns do, and then at that point they have the option of applying to the CARE track, which is actually also a mentored project during your 2nd and 3rd year. And then just for a little different perspective, New York Hospital, there are 2 3-week rotations during 2nd year, and these revolve around a longitudinal group project that residents do. So some of the factors that were involved in instituting an advocacy curriculum at Mount Sinai, we had some challenges. We also had some assets. Some of the challenges were that we actually had no dedicated faculty time. So we had a lot of interested faculty, and people were willing to donate their time, but we really did not have any designated time. We actually had no money to do this. And again, we had people willing to donate some money, but we didn't really have any financial resources specifically dedicated to this. We had also experienced there were changes in leadership at some of the local community organizations that we were working with, but again, we were able to identify other community partners who were really eager and wanted to work with our residents. And we also have a wonderful school-based health program, and we felt that that would be a really great opportunity for residents. So in order to design the new curriculum, we said, let's think about the things that are the major challenges for our patients, what resources are available in the community that residents can learn about, and also make it very relevant, because I knew that in order, and I'm sure you all know, in order to engage learners, it has to be something that they're excited about, that they feel will make a difference, that's relevant to their lives. And the topic that kept coming up over and over again was obesity. It's something that our residents deal with every day. I would say about 40% of the patient population that we see in the pediatric outpatient department is either overweight or obese. So we felt that this was a very relevant topic. And again, we know that obesity is strongly influenced by a variety of psychosocial factors such as poverty, food insecurity, cultural norms, and the actual built environment. So we thought that obesity could be used as a paradigm to teach residents core advocacy principles and skills. So what were the components of this curriculum? What did we put together? And a lot of this, I have to say, depended on sort of what the strengths and resources were that we were able to identify from within and in our community. We had didactic sessions and readings on advocacy and obesity core topics. We actually had residents do home visits to the homes of families who were struggling with obesity to see what the home environment looked like. Do they have a TV, right on the dining room table? Is there a dining room table? What kind of food do they have in the home? What's the environment around their home? I mean, do they live in a neighborhood where the child really can't go outside to play, or they're not close to a playground? So things like that. They visited a local elementary school to look at the gym class, if they had gym class. What's the cafeteria like? What's the food like that they're serving? Do they have recess? And I was actually amazed to learn that at the local public school that they went to, gym class was not even once a week. It was often less than that. And sometimes in gym, they would divide the class in half, and half the class would sit on the side and half the class would exercise. That was news to me. They did a pre-participation medical screening exam for a weight loss program that we have here in the clinic. They ran a session actually for children in an after-school program that was run by the Y, and they visited a variety of community-based organizations that dealt specifically with nutrition and exercise programs. So the objectives of our study were to evaluate the impact of this curriculum on knowledge, practices, and attitudes about both obesity and advocacy, and then assess resident satisfaction. And our hope was that after participating in the curriculum, they would improve both their obesity knowledge as well as their advocacy knowledge and skills. So we had all second-year residents at Mount Sinai who were rotating through, participated in the curriculum during their 4-week advocacy block. We administered questionnaires before and after, and the items on the questionnaire were drawn from previously published validated surveys that looked at obesity knowledge, management, comfort and ability with accessing obesity resources, and also core advocacy skills. We also asked them to complete a self-reflective essay, and we also gave a survey on basic resident satisfaction with the curriculum. So our results, we had 15 residents who completed the rotation. We had data available, pre-data was available for 15, and then we had post-data available for 13 of the 15. Here you can see the scores on the obesity knowledge exam. Pre-rotation, the residents were scoring about 61.25%. Post-rotation, the scores went up to 75.5, and as you can see, that was significant, so we were pretty happy with that. I think they could do even better. So it did identify some areas that we weren't doing as great as we should have. looking at their advocacy knowledge and self-efficacy, we found that in a few domains there was a nice improvement. So, for example, their comfort and ability assessing the needs of children in a community improved from 3.07 to 3.92. Their comfort and ability identifying and accessing resources for children and families also improved, and their perceived knowledge of obesity community resources improved from 2.73 to 6.9, 3.69. As you can see, they were all significant. And we were pleased about that. Again, I think it was measuring what we hoped it would measure, what we were teaching them, but we were pleased with those results. And then in terms of overall satisfaction with the curriculum, as you can see on a scale of 1 to 5, with 1 being very negative, 5 being very positive, residents actually rated almost all of the components of the curriculum as very positive. And I would say 10 residents rated all experiences as somewhat or very positive, 2 rated 1 to 2 as neutral, and 1 resident gave a somewhat negative rating to 1 experience. So overall, we had positive feedback on the various components. And I just put up a few comments. I thought that we haven't formally done a qualitative analysis yet for the writing piece, but one resident said, "I think this rotation gives residents the perspective needed to make our assessment, anticipatory guidance, and treatment work in the framework and realities of the challenges our children and their families face every day." And another one said, "Learning about advocacy activities at different political levels and learning about the work in specific communities by the Department of Health, community advocates, and organizations like Strategic Alliance for Health reminded me that disease is a function of the environments that people live and work in and the culture people belong to, as well as a function of physiology and genetics." And that really, there were a lot of other comments that I thought were very telling, but I found that very telling. Which is what we wanted them to learn. It's not just physiology, it's not just your genetics, it's really the environment that you're in, the opportunities that are available to you. So in conclusion, a new curriculum which uses obesity as a means of teaching advocacy and community pediatrics improves pediatric residents' obesity knowledge, as well as their comfort, ability, and knowledge with obesity, of advocacy and community pediatrics. And furthermore, overall satisfaction with the curriculum and the components was high. So I can just point out some of the limitations. It was a small sample size. We had 15 residents who were rotating through. It was done by self-report. And there may have been response bias. I hope not. It was completely anonymous. But people may have wanted to please us or may have been afraid to be honest. I would hope that's not the case. And as a result of doing the curriculum, what we realized was this was great, but we really need to widen the experiences that we're offering. And they need to get a broader perspective. There were certain community-based organizations that I felt we weren't reaching because they weren't specifically in the obesity or nutrition domain, such as REAP, WIC, the Asthma Center for Excellence. And we also, again, from interactions we had with other programs across the country, we started realizing that resident projects are really quite valuable. And if we could somehow work that into the rotation, that would be a real advantage. So we had a number of opportunities that came up since this was Medical Education Research Day last year. In January of 2013, or prior to that, I received a grant from the AAP, the Leonard P. Rome Visiting Professorship Grant, to establish a conference that we had in January 2013, the New York State Pediatric Advocacy Coalition Conference. And basically, it was a kickoff event for programs around the state and really the tri-state area who are teaching advocacy to residents and medical students. And we're hoping, and it was a 2-day conference, and subsequent to that, we're seeing a lot of increased collaboration and sharing of resources between pediatric residency programs throughout the city and New York State. And future directions, because of changes that are happening, I know it's happening in pediatrics, I would imagine other residency programs. In general, changes in the actual overall curriculum, there are new opportunities to integrate advocacy throughout the 3 years and at multiple different points. We're going to keep the block format, but also add more longitudinal experiences, and we're actually going to create an advocacy track, similar to the ones I mentioned at Sanford and Rochester, for residents who self-identify and are interested in having more time to do advocacy work. And as a result, we've also had some more faculty time dedicated. So that's also been a nice benefit. I'd like to actually thank my division. As I mentioned, this couldn't have happened without the dedicated time of all the people that I work with, my co-authors, and the Pediatric Resident Advocacy Group, which is a group of pediatric residents who meet monthly to work on advocacy projects, come up with ideas, do research, and that's also been a great help for us. So, thank you.
Our next presenter is Leora Gelfman. I think Leora needs no introduction for many of us here, but Leora graduated from the Mount Sinai School of Medicine. We lost her for a little bit when she went to do her residency at Weill Cornell, and she returned to complete her fellowship in hospice and palliative medicine in June 2011, as well as a dedicated year-long research fellowship in the Department of Geriatrics and Palliative Medicine. In 2012, she joined the department as an instructor. And the goal of her research is to better assess the effect of palliative care consultation on healthcare utilization and costs of older adults with heart failure. Of note, Leora was also a Doris Duke Clinical Research Fellow, so I know Karen will be proud of her. And she is presenting to us today on assessing communication skills in fellows using a clinical examination tool.
Joking that in some ways this is the most intimidating audience, like people who have helped support me throughout the whole trajectory. So today I'm going to talk about an innovative direct observation communication skills assessment tool that we developed with the thought that it would be a way to prepare for the next accreditation system. So 2 primary learning objectives are to recognize the need for a real-time communication assessment tool and to identify the potential role for the tool within the context of the next accreditation system. I have no disclosures. So why communication? So in the fields of palliative medicine and geriatrics, communication skills are really fundamental. These providers and these trainees really are taking care of patients who are facing the most serious illness and challenging clinical scenarios. Put another way, in this New Yorker cartoon, there's no easy way I can tell you this, so I'm sending you to someone who can. And very often that someone is someone in geriatrics or palliative medicine when the clinical scenario is the most complex. So humor aside, we now actually have evidence showing why good communication actually matters. So we have evidence that it actually improves outcomes. So lowers costs of care, decreased family burden, improves family satisfaction, and actually improves bereavement outcomes. So we know that communication is important, and we know that we need to train our trainees in great communication skills. The next question is, how do we assess whether or not they're actually skilled communicators? So that's the primary focus of this. In addition, it's really critical for the next accreditation system, which you all know better than me, is really built on requiring ways to assess our trainees in their milestones and entrustable professional activities. So we need ways to actually evaluate them. And the existing tools, specifically for communication, don't focus on clinical encounters, and they don't occur in real time. They're really focused on using standardized patients. And additionally, they don't target specific communication skills. It's sort of a more overall assessment. So we decided that family meetings are actually a great opportunity to assess communication skills. And we defined family meetings very broadly. So really as any conversation that a trainee would have with a patient and her family involving discussions about their treatment plan, their goals of care, their transitions, and just really tried to say anything involving those things. So the objectives of our research project was really to first develop this actual communication skills assessment tool, and then to test its reliability and feasibility of use, and then to really see if the tool could identify areas of further training. And finally, to evaluate how satisfied the evaluators were with the tool itself. So a group of faculty from geriatrics and palliative medicine came together, those with some expertise in communication skills, and compiled a comprehensive list of all the communication skills that might be used within a family meeting. And really it became sort of a checklist, which was really designed to highlight potential communication skills gaps So what are the fellows really not doing? What are the skills that they're not able to perform? And then we agreed on basically definitions of each of these skills and developed a training manual that could be used right alongside with the assessment tool to ensure that we were all speaking the same language and had a shared understanding of each skill. Next, we held a training session where all the faculty came in, and we conducted 2 mock family meetings, and in real time used the assessment tool to evaluate the communication skills of the happened to be a nurse practitioner conducting the meeting, and came together and made sure that we could reach consensus and agreement on how we were defining the skills and whether or not the skills were used in the mock family meeting. Next, we obviously enrolled all the fellows. They went through informed consent, and they agreed to participate. And we put the responsibility on them to identify the family meeting opportunities, using, again, this broad definition of a family meeting, encouraging them not to include sort of the mega family meeting with the 10 consultants and the 10 family members in the room, but really a really simple, pared down, basic, straightforward family meeting. And 2 trained evaluators observed each of the family meetings and independently completed the assessment tool in real time. So they sat in within the family meeting, introduced themselves as observers, and with the checklist, they went through and evaluated whether or not the fellow completed the individual skills. After the family meeting, the evaluators came together and went through each individual skill and decided whether or not they thought the skill was demonstrated, and then came to a consensus. So here's sort of a snapshot of what the assessment tool looks like, and you can see in the left-hand column is within each row is individual skills that were included, and then the subsequent columns are NA for not applicable, meaning the skill wasn't appropriate. So if somebody was talking about getting discharged to a nursing home and what that would look like, it might not be appropriate to talk about the things that you would expect to see when somebody's dying. So in that case, it would be not applicable. If the skill should have been used, or we thought should have been used and was not used, then it was a no. And if the skill was used successfully, it was a yes. We also included the columns of beginner, intermediate, and expert to give a more subjective assessment so that there could be a more enhanced feedback, but we didn't actually use this in our analysis because we didn't really have a clear grounded definition of what each of those levels of expertise would look like. So the tool included 32 distinct skills, and I mentioned how they were evaluated individually. So we then went one step further and tried to identify within this list of 32, what are the really core fundamental skills? And we worked with 2 national communication skills experts to really say what are the minimal skills that are required to competently run a family meeting, meaning sort of like the lowest level, do no harm. What do these fellows need to be able to do to run a family meeting well? So we have these 8 skills. So the first is to greet the patient and or family. So make appropriate introductions and explain their role within the family meeting. To assess the patient and or family's understanding. To give information in a balanced manner and clarify any potential misconceptions that they have. To avoid the use of medical jargon. To check for the patient and family's understanding after they've given all this information. To use empathic continuers, which is a term that was coined by James Tulsky, that really are these statements of which really directly assess and address the patient's emotional sort of level and validate their emotions. Used open-ended questions, so tell me about your mother, and finally provided a summary and again assessed their understanding at the end of the meeting. So we evaluated the tool based on 4 outcome measures. The first is the feasibility of actually completing the assessments in a short period of time, the inter-rater reliability and consensus, the ease of identification of areas for further training, and finally, the satisfaction of the evaluators with the tool. So 10 fellows participated in the project who are all first-year fellows in either geriatrics or palliative medicine here at Mount Sinai or at the Bronx VA. 8 of them are female, 6 are palliative medicine fellows, 3 are geriatrics, and 1 was in a combined program of geriatrics and palliative medicine. 60% of them reported a prior communication training, and the majority of them were trained in internal medicine. So we also had them assess their sort of baseline level of comfort and competence with communication skills. And the majority of them, for both assessing giving bad news and discussing goals of care, reported that they were competent with either minimal supervision or competent to perform independently both these things, both giving bad news and discussing goals of care. In terms of feasibility, in a 5-month period, all 10 fellows we were able to complete assessments. 5 of them were able to identify a family meeting more than 24 hours in advance, with a range of anything from 90 minutes to 72 hours. You can imagine what getting 2 evaluators in the room in 90 minutes looked like. And the mean duration of the actual family meetings was 37 minutes, with a range of 25 to 50 minutes. The mean inter-rater reliability was 0.68, and the paired evaluators were able to reach consensus in all cases. So this is where looking at whether this tool actually can identify areas for further training or these communication skill gaps. And you can see that in the 4 columns or bars on the left that the majority of them were actually able to complete these skills. So the majority were able to successfully do greeting, assess understanding, give information, and avoid medical jargon. However, in the columns 4 bars on the right, you see that the minority of them were actually able to complete the skill. So we really see that there was, one, a wide range of skill level, but also these are all residents who had completed internal medicine and family medicine training, and yet they're still not able to complete what we've deemed the sort of minimally competent skills that they need to perform a family meeting. And furthermore, they're also, self-selected to want to communicate because they've chosen to pursue careers in geriatrics and palliative medicine. The evaluator satisfaction was high. 65% of the evaluators reported that they were extremely satisfied, and 35% moderately satisfied. So in conclusion, this is a novel real-time communication skill assessment tool that is both reliable and feasible. And this assessment is really critical for going forward, in particular in the context of the next accreditation system, for fellowship programs to be able to target specific communication skills, to provide these learners with direct, formative feedback, and to guide further training. So our next steps, the exciting news is that this tool is now a standard part of the both geriatrics and palliative medicine fellowship program. We hope to craft the tool for dissemination to other programs, and we've now completed repeat family assessments after the fellows participated in a focused skill training, which you guys may have heard of as Geriatrics. And with that assessment, we're looking at specific communication skill acquisition and whether or not they've integrated the model of deliberate practice to their communication skills. So I want to give special thanks to all my co-investigators, 3 of whom are here today, Amy Kelly, Elizabeth Lindenberger, and Helen Fernandez, as well as Gabby Goldberg, Betty Lim, Jenny Latrivis, Lynn O'Neill, Cardi Smith, and a special thanks to the fellows who participated. Thank you.